these are some journals that I take to review for this talk. And one of them is that spinal metastasis is one of the tumors that can happen, and most common site is at the bone, in which it's most frequently involved. Well, the goal of surgery is to do a pain relief, stabilization of the vertebral columns, and the compression of neural elements, and tumor cytoreduction. For a systematic review, try to take the symptomatic metastatic epidural spinal cord compression. There's 11 publications eligible, and most of them shows three techniques that are commonly used with this minimal. The video-assisted thoracostomy, as you can see like this. And then also endoscopy-assisted posterior decompression and minimal access surgery, and mostly with the tubular retractor. Based on those systematic review, they found out that minimal invasive spine surgery can really minimize soft tissue surgical trauma and accelerating post-operative care. And then fast and mass have reduced operating times, and mean complication rates were lower than open surgery, and mean blood loss and mean length of stay was reduced. So it is a class 4 data that's suggesting both of them are good, meaning to achieve good neurological improvement and pain in the treatment of metastatic spine disease. And as you can see, most have, another journal said that there are 4 types of most intervention, which is a gold standard, especially the posterior instrumentation is the gold standard. And they have several cases trying to compare, and posterior instrumentation have quite the same median postoperative KPS. And dorsoventral instrumentation with vertebral body replacement is also quite the same. And posterior decompression only also quite the same. But interestingly, kyphoplasty have a good increased postoperative KPS. So when they do surgical treatment for spinal metastasis, they try to do it in a stage position. So if the board says you can do this, posterior instrumentation with decompression and radiation and chemotherapy, we do it. But if there's an osteolytic vertebral body and slowly progressing systemic disease, you should add for anterior vertebral body replacement. And then if this unfit for instrumentation and also have a pathological fracture, a kyphoplasty or biopsy only is better. Meanwhile, if there's an osteoblastic lesion and no instability and epidural compression, a good decompression is actually enough. I actually have one patient, but with just a decompression, and I have a good pain reduction for the spinal metastasis. And so posterior instrumentation and decompression is the first step, but the rest is usually a stage invasive surgery. And currently there is no level 1 evidence. And then another journal would say that primary tumors are used, the indication is, the target is curative intent, meanwhile metastatic tumor surgery for symptom palliation. And the key component for minimal access surgery was percutaneous spinal instrumentation, tubular and expandable retractors for transmuscular approach, and lately with neuronavigation and endoscopic and robot-assisted surgery. For spinal stabilization, the best was vertebral segment augmentation with kyphoplasty and vertebroplasty. And the next gen is we have done quite so much for percutaneous pedicle screw instrumentation for pathologic fractures, added with cement augmentation and fenestrated screw. And then for tumor excision and decompression, we use mini open approach and combine with PPSI. And then for neuronavigation, endoscopy can decrease the invasiveness of spinal surgery. Thoracoscopy, endoscopic system for posterior approach, robot-assisted surgery, and even ablation techniques. Now, what about the indications? Usually, for benign epidural tumors of the spinal column, usually the cases are osseous benign tumors. They can do CT percutaneous ablation techniques. Even symptomatic vertebral hemangioma, we can do a percutaneous cement injection, and also transtubular or endoscopic tumor excision. Meanwhile, for intradural tumors, we usually can approach with paramedian incision and a tubular retractor, and sometimes hemilaminectomy with undercutting of the spinous process with a conventional microsurgical technique for the intradural dissection. And back for the metastatic tumor, also the same with the previous journal. This is an example of a patient with metastasis at the vertebral. So they did a cement augmentation and put percutaneous fixation with cement augmented over the screws with fenestration. And also this is another example, actually medial compression only done with percutaneous screw insertion but without cement, so the posterior area doesn't actually compress more of the nerve. And then this is also a case of multiple cases, but they do a minimal invasive open surgery to put the cage inside also. So actually I have a case with post-operative of a big tumor, schwannoma, and it became with LCS CSF leakage. So I use a small incision at the here area and try to find the LCS leakage and give us some, after getting the water out, I give some berry plus or for putting for closure of the dura. And I also do skin suture for to have a good reduced dead space. And this is the post-operative. So I think for these days, minimal novel spinal instrumentation and intraoperative navigation and imaging can have less invasive surgical approach, and those combination can create minimize blood loss of tissue injury and length of hospital stay. Thank you. And by the way, please, I would invite you if you want to come towards Spine 10, and as you can see, this is Bandung and this is Jakarta, the capital city, and we're just a 45-minute flight to Bali. Thank you.